This is QD Clinic. Hi, I'm Jack Cush with Room Now. QD Clinic is brought to you by Room Now Live, March 19th and 20th coming up. Today's case, when the labs and the exam don't quite agree. A 38-year-old woman with a year and a half of left knee pain and low back pain comes in to her primary care doctor complaining of 10 out of 10 pain and the same. He does lab tests, finds a rheumatoid factor of 97, normal SED rate, sends the patient to you, the rheumatologist. When you see the patient, there's polyarthralgia and still some low back pain. She says her pain is now a 7 or 8. The patient was already started on meloxicam and hydroxychloroquine and is getting modest, if no relief. She's taking tizanidine for her back pain. She has all-day morning stiffness. You examine the patient and you get 2 tender PIPs and 2 maybe swollen knees. And you think, this could be rheumatoid, but there's seems to be a lot more here than you're seeing. So let's get some labs, continue the treatment, and labs come back crazy, like overwhelmingly rheumatoid. Rheumatoid factor is 250, CCP is greater than 250, CRP is 111 milligrams per liter, the SED rate is 129. The ANA was negative, uric acid was done by someone else, was negative, Hep B, Hep C negative. And the question is, overwhelming labs for rheumatoid, underwhelming exam. And I think that this happens more frequently than we would admit. In fact, there's probably several different types of discordance that we can see. One is when tender joints are far greater than swollen joints. Well, 9 times out of 10, that's fibromyalgia or depression. Really puzzling when they've got a lot of swollen joints and they say the swollen joints don't hurt. We tend to think of that as happening in burnt out patients who have burnt out disease, not burnt out, it could be burnt out disease, but patients who had chronic, severe, ongoing inflammation, maybe that they don't have, nociceptive receptors anymore, and they don't feel pain the same as you or I would. That's another one, and that's a real challenge. When there's a discordance between the physician global assessment, shall we say, and the patient global assessment, physician global assessments are often driven by swollen joints. Patient global assessments are driven by pain and maybe tender joints. And the worst of all might be when nothing on exam and a lot of crazy looking labs, meaning abnormal labs, that there's something brewing probably, something going to happen probably. Or the converse, when the patient has normal labs but a horrific tender exam, well, again, that's fibromyalgia, depression, and other things, not usually organic or inflammatory disease. I think a few things worth mentioning here about discordance. Number one, recognize that your MD global is driven by swollen joints. The patient global is driven by pain. Secondly, John Kay and a few others, Dan First wrote a paper a few years ago showing in a fairly large cohort of a few studies of RA patients, 58% had a normal SED rate in CRP, even though they had active disease. The point of the paper was that maybe such patients don't get into clinical trials because they don't have all the elevated core SED variables that you need to have very active disease. In that study, they also had 16% that had both of them elevated. So we rely on SED rate and CRP, but often they sort of let us down, and that's unfortunate. I think maybe the truest teaching on this comes from Ted Pincus, who says, we rely on our tender and swollen joint exams, but that's not the whole story. And often, they lie to us. Patients get better on placebo as far as tender and swollen joints. Patients get better in a lot of different domains in clinical trials, even though they may be on placebos. And that it is a combination of things you have to rely on, especially self-reported outcomes, PROs, patient-reported outcomes, again, which could include everything from pain to number of tender joints to the health assessment questionnaire or HAC-DI. There's a number of things that you can rely on here. The point is that you need all of these to make an accurate and true decision regarding treatment. So the bottom line is when you find that discordance, it's time to pause and reevaluate. I think that, the more, and then look at multiple domains of outcomes when you're seeing patients. And then the more of those that are abnormal, the more that you can act on them. I never treat a lab alone, right? If this patient had a normal exam and scary looking labs, I would just continue to follow the patient. Let's say this patient had no swollen joints, no tender joints, and had those labs. I would be doing an SPEP. I would be doing Hep B and Hep C. I might be doing a liver ultrasound if the liver enzymes are elevated. This patient had a marginally elevated alkaline phosphatase and an AST of 45. Alkaline phosphatase, I think, was 235. Rheumatoid arthritis commonly, the disease itself will elevate your alkaline phosphatase, maybe like 50, but no more than 100 points. If it's more than 100 points above your upper limit of normal, you really need to think about evaluating for liver or cholestatic abnormalities in that patient. I thought this was a challenging patient. Come to Room Now Live. Let me tell you why. When we had our very first Room Now Live, we asked people to come, and a lot of people did come to the live meeting. A lot of people tuned in virtually online. We were sort of the first to do a hybrid meeting. But those who sat through the first day of the meeting and the whole meeting, they all came up to me at the breaks and at the reception in the evening and said, this is so much different than any other meeting I've been to. And I can't quite put my finger on it, but it's really engaging. And what are you doing here that's got me, that you've tripped another trigger in my head as far as learning? And the secret sauce here is shorter lectures, more discussion, panel discussions, these short TED-like talks that we call step talks, but they're amazing. We're going to have 3 of them this year, one on pregnancy and why you shouldn't stop your drugs during pregnancy, another one on the death of Caravaggio by Peter Nash, and the third by Ronan Cavanaugh, who's going to talk about the music of rheumatology. What does that mean? I don't know, but I know it's going to be interesting and different. So think about attending either online or on site. We'd love to see you. Tune in tomorrow for more QD Clinics.